Hi everyone, my name is Andy Steiner and I am a fourth year medical student at the Fort Collins branch campus of the University College School of Medicine, and my talk today is titled Ouch Ouch I Can't Move My Arm, a virtuality review of traumatic brachial plexopathy. So our case overview, we have a 25-year-old male who was brought in by ambulance to the emergency department for evaluation after getting hit while he was stopped at a stoplight on his motorcycle. He was wearing a helmet and leather protective gloves and a jacket, all of which sustained relatively minimal damage. He denies any loss of consciousness. However, some bystanders indicate that he was unresponsive for roughly 60 seconds. He arrived in the emergency department hemodynamically stable. He's in the Marines, in great physical fitness, and has no previous health conditions or surgeries. His chief concern in the emergency department was severe pain and inability to move his left arm. So an approach to any trauma patient, the primary survey, you can be evaluated is using the mnemonic ABCDEs. So A for airway, that was intact because he was phonating, talking to us, able to indicating he's able to protect his airway. For B, breathing, his trachea was midline, breath sounds were clear bilaterally. He was over 90% on room air. Circulation is carotid, radial, femoral, and pedal pulses were all present and equal bilaterally in all distal extremities. So D stands for disabilities, really a focused kind of neurological exam. His pupils were equal, round, and reactive to light. He was following commands in all of his extremities except his left upper extremity, in which his sensation was decreased and he was unable to move any muscles below his left trapezius. So for E, which is exposure, you just look at all of the tissue and make sure that there aren't any abrasions or contusions. He had those on his left upper extremity only. He did not have any significant lacerations. He didn't have any edema or pooling of blood, and he was also normothermic in this indication. You can also use F for a FAST exam in a trauma evaluation as well. FAST stands for I always forget this, focused assessment and sonography and trauma, and he was FAST negative. So the vital signs for our patient here in the emergency department upon initial evaluation, his temp was 98.2, blood pressure was 139 over 100, heart rate was 88, indicating he was dynamically stable. His respiratory rate was 18, he had a pulse ox of 98% on room air. So on his secondary survey, which is a more in-depth physical exam and review, and that's really designed to elucidate any additional non-life-threatening injuries, that was mostly normal. I won't go through all the details, but one thing that I would like to highlight over here is on his extremities. Actually first on spine, he had no cervical, thoracic, or lumbar tenderness, no step-offs or deformities. He had a stable pelvis to rocking compression. He had no evidence of any long bone deformities. And then in his extremities, he had movement and sensation was intact in bilateral lower extremities and in his right upper extremity. However, in the patient's left upper extremity, he had no sensation in the nerve distributions of the musculocutaneous medial ulnar and radial nerves, and no movement in those same distributions. And there is mild sensation over his deltoid, so axillary nerve distribution, and then partial engagement of his deltoid and engagement of his trapezius as well. And he had some mild ecchymosis or bruising on his left bicep and medial arm. No abrasions or lacerations again. So in terms of imaging studies obtained for this patient, because he was evaluated in the ED and trauma, and because radiology and emergency physicians are in cahoots, this patient got a pan scan, so CT chest, abdomen, pelvis. He also had some radiographs as well that we won't talk about, but because he had some altered mental status or at least a significant mechanism of injury, he received a head CT. All of these imaging scans didn't reveal any kind of occult pathology or any explanation for his current chief concern. Head CT didn't reveal any acute intracranial pathology. So no bleeds, anything like that. And then because of his chief concern of upper limb weakness, he got a brachial plexus MRI. So the technique for that was multiplanar, multi-sequence MRI of the left brachial plexus with and without contrast, 1.5 Tesla. So some relevant findings for that: partial traumatic nerve root avulsions with a pseudomeningeal at the left C3, 4, 5, 6 nerve roots, some visualized portions of the corresponding brachial plexus nerves, are enlarged, and T2 hyperintense, indicating kind of a nerve root injury. And then the distal portions of brachial plexus are not able to be well evaluated secondary to a susceptibility artifact. And I believe the susceptibility artifact is this large portion of lacking data in our scan over here to the right. So moving on, over here on the left, we have an image from the MRI of our patient, and then we also have an image from Radiopedia, just kind of outlining some of the relevant pathology, or anatomy rather. So for this, I'm going to move now over to our scan, and I'm going to pull this a little bit closer. So here we've got a virtual reality 3D rendering of the MR, and this particular MR sequence is a T2 MR. So that means that we're going to have both fat and water or fluid is going to be hyper intense or show up bright on these. And one of the things I've also done is I've gotten this cross section here. So this is an image from the MR, and then here we can kind of see, again, just kind of orient ourselves to the vertebral bodies. We've got C2, C3, C4, C5, C6, C7, and then T1 right here. We can know that by just kind of following the ribs that come out from T1. Okay, and then you've got spinal cord. There we go, right there. And then some of the nerve roots coming off of that. You see some of these hyper intensities that they're talking about right here. So then we can move back up our transparency on this, and then what we can do with this is we can kind of go ahead and adjust a little bit some of the histogram to be able to get a better visualization of some of the structures. And then here we can just go back and take some slices through, and again we can see some of the like hyper intensities that they're talking about right there. Back into the spinal cord. So this section right here is some of the hyper intensities, and then up in here as well. Okay, pull this back out. And then those are kind of displayed over here in this section as well. So moving on to a different view. So now what we can do is we can, not the cross section, we can move this entire scan around and be able to kind of get and orient the lateral view as well. So one of the things I like to be able to do with this is change this a little bit and be able to see some of the different structures, so we can really identify some of the neurovascular bundle that we have here. Again, take this cross section and position this cross section here on the scan. And then we can kind of find a similar location here. So that's about similar to what we were looking at over on that other slide. So interestingly, you can kind of see more detail over here than you can with this. You know, I think the just interesting challenge with how these scans get uploaded. But here we were able to kind of clearly identify it, at least at this point right here, some of the neurovascular bundle that we have. And then if we go ahead and increase our transparency, we see that we have directly circled what appear to have some of the neurovascular sections of this scan. Let me see if I can adjust this a little bit. There we go. And then, yep, right there we see some of the different neurovascular sections. It's difficult to really discern kind of what is nervous tissue versus what's vascular tissue at that point, but then we can kind of go in a little bit and see, adjusting this a little bit more just to kind of see what we can discover. At least, you know, when we bring this cross section forward, we see, again, kind of some of the neurovascular right there. Moving on in. And again, so what we're looking at here, this would be the axillary artery at this point, and then the branches of the brachial plexus here. And then as we kind of move this back, undo that line just so that's not confusing us. Reduce for transparency, then we are able to get cross-sectional information right here. Again, some hyperintensities right there. Moving on out, again, this is where we see that artifact. We're not able to make out some more additional hyperintensities right there. And then moving this axis in a little bit, increasing this. Again, we're kind of able to follow. Okay, that's the plane of the hyperintensity where we are seeing some of that. Reducing that down. And then again, here is where we would expect to see nerve roots exiting right around there. So going back in, we can kind of see some of the nerve roots exiting right around there. All right. And then, so diagnosis and management, again, we've had some avulsions of these nerve roots, resulting in exopmesis and neurotmesis. Probably not pronouncing those right, so forgive me. And then the management of this, you wait for the swelling and inflammation to decrease. In the setting of possible neuropraxia, you can consult physical and occupational therapy just to really evaluate and work with the patient to see how much of those nerves will heal or regrow. Eventually, you get some electromyography to be able to evaluate quantitatively the extent of the nerve injury and identify kind of exopmesis, neurotmesis, and then you could go forward at that point once you've evaluated them with some surgical interventions that this patient had proposed. So ulnar nerve to brachialis motor nerve, pedicle transfer, a median nerve to biceps motor nerve, pedicle transfer, spinal accessory to suprascapular nerve, pedicle transfer, a radial nerve to axillary nerve, pedicle transfer, and then extensive neurolysis just to address some of the neuropathic pain that this patient was experiencing. And just a reference for some of our brachial plexus anatomy that we have. And then, a lot of these are also locations where you can do local anesthetic injections for specific either shoulder or distal arm surgeries. And I want to say thank you for listening to my talk.